Now, for those of you not familiar, the mission of CHAI is to advance interdisciplinary aging science, create meaningful and immersive educational experiences in aging, build and sustain innovations in care and services, and establish vibrant community, governmental, business, and individual collaborations to promote healthy aging for Minnesotans and people across the country. CHAI has 5 cores: education, research, policy, equity and community engagement, and clinical science and practice, with many of the associate directors in the audience here today. Our director, Dr. Joe Gogler, is the Robert L. Kane Endowed Chair in Aging and is here today as well. Now, before we begin today's presentation, I want to take a moment to acknowledge and extend our gratitude to our sponsors. I want to give a special thank you to Minnesota Department of Health for their supported gold level sponsor. They sponsored this morning's community conversation, where Dr. Fabius had the chance to engage directly with the members of our community advisory board. I was at the breakfast too, led by Robin Fraser, the Associate Director for Community and Equity Core, and it was just so special to connect with the community members. And we deeply believe in CHAI that it is so important to prioritize connections in our local communities. In addition, we are very grateful for the support for the Department of Human Services, our premium level sponsor, and thank you, Rachel, for being in the audience here today. Their partnership allowed us to extend the reach of today's presentation, helping to bring Dr. Fabius's important research to a broader audience. This collaboration highlights the alignment of our missions, and we are grateful for their commitment to promoting education and improving the lives of aging Minnesotans. It's a privilege to partner with the state agencies that share our vision for creating a better Minnesota for all. Now, it is my pleasure to introduce our esteemed speaker, Dr. Chanee Fabius. Dr. Fabius is an assistant professor in the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. Dr. Fabius is a recognized gerontologist and a health services researcher whose work informs aging and disability policies to reduce healthcare disparities and improve health equity for older adults and people with disabilities who use long-term services and supports. Her current research focuses on strengthening the direct care workforce that provides services and supports to vulnerable older adults living in the community with multiple chronic conditions like dementia. Dr. Fabius's interests are informed by her applied care management experience, where she helped older adults remain at home and delay the need for nursing home care. Now, I've had the honor of knowing Dr. Fabius for the last decade and have been truly inspired by her work, and I'm so excited that we can host her here today. So please join me in welcoming Dr. Fabius.
Wonderful. Thank you all for having me. Thank you, Tatiana, for the wonderful introduction. It's so good to be in the company in person with some of my favorite colleagues. And I saw John walk in. John used to be at Hopkins with us before he returned home to Minnesota. And I also have to acknowledge Shekinah Bashaw Walters, who's in the back, one of my good friends in academia. And before I get started, I have to acknowledge, because I'm sure most people don't bring their partners with them to their jobs, but somehow a little boy from Connecticut became a top Minnesota Vikings fan. And so when I got the invitation to come out, we had to make a weekend of it. So we were able to go to the Minnesota Vikings museum, right? We did some shopping. We went to the game yesterday. Thank God they won. It would have been a different kind of weekend, different kind of trip. But my husband Steve is here, and so I just wanted to acknowledge him. And so I guess today is Bring Your Husband to Work Day. So he's not seen me talk about my work since my dissertation proposal or defense. So you guys have done something special today. So I'm going to go ahead and get started and talk about a topic that is near and dear to my heart, which is paid care and supporting diverse older adults and their family care partners. And as Tatiana mentioned, I approached this work with former caregiving experience, family caregiving experience, as well as care management experience. I was a Connecticut care manager for the Connecticut Home Care Program for elders for a few years before going back to school and beginning my work in research. And so I want to acknowledge, and you'll see a few familiar names on this slide, but I would like to acknowledge my mentors as well as collaborators for mainly the two primary projects that I will talk about today, as well as my funders. But I want to especially acknowledge my community partners that I work with in Maryland. So, of course, I partner with the State Department of Health for some of my work. The Maryland National Capital Home Care Association is an association that supports home care agencies in the Maryland and DC area. And then the Hilltop Institute at the University of Maryland, Baltimore County is also a partner in some of the work that I do. And so I'm happy again to be here and going to be covering a few different things. First, to provide an overview, the who and what, right, of home and community-based paid care. I will talk then about some of the work that I've done in to examine and understand racial and ethnic differences in paid care. And I'm going to share some of what's been taking up the bulk of my time over the last few months, this concept of role sharing and how family caregivers and paid caregivers collaborate in paid caregiving. And then finally covering some strategies to strengthen paid care delivery. And so paid care is delivered in home and community-based settings to address the needs of individuals with limitations and activities of daily living, as well as instrumental activities of daily living. Paid caregivers assist with these routine activities that can be delivered in traditional community settings, as well as residential care, such as assisted living. And of course, we know that, well, many of us know that paid care is often funded by Medicaid home and community-based services. Medicaid is the largest or primary payer of long-term services and supports, but it can also be financed by private pay. And I put Medicare home health here because although Medicare home health is traditionally an acute a service or provided for acute care or post-acute care, excuse me, we know that in recent years, more people have been admitted without a prior hospitalization, especially people who are living with dementia. And so I included in the universe of when we talk about paid care here. And so as a result of rebalancing efforts over the past several decades, many states have shifted their Medicaid financing from being predominantly spent on institutional care to community-based services. But we know that that varies tremendously by state. And so we can't have this discussion about paid care without talking about how it exists in the context of Medicaid LTSS rebalancing strategies. Over the past several decades, we see that states have invested more money in home and community-based services, less in institutional care, and a lot of these changes were or further advanced as a result of the 1999 Olmstead decision, where the Supreme Court held that people with disabilities have a qualified right to receive state-funded supports and services in the community setting of their choice. And so as you can see, in or around 2012, 13, 14, we see a switch, right? Where a higher percentage of state LTSS funding begins to funnel towards HCBS rather than institutional care. And so this has really changed the way in which states strategize to support older adults and people with disabilities in the community. And as you can imagine, as many of you know, the percentage of Medicaid LTSS expenditures for Medicaid HCBS varies by state. So this map shows those percentages by quartile. And this percentage is often referred to as Medicaid HCBS priority or Medicaid HCBS generosity. And so one of the questions that came up during the community conversation this morning was about examples, states, right? Where do I look to for examples? And I said, I look to Minnesota. You guys are doing something right. You can see that you all, 80% of your LTSS financing in 2020 was going towards community-based services. You guys were in that fourth quartile. In my home state of Connecticut, we're at around 57%. And where we live right now in Maryland, we're at about 62. So we're not doing too bad, but you can see that there is tremendous variation around the country. And so we can only imagine what that looks like, right? In terms of the availability of services, the support for the direct care workforce that provides them, so on and so forth. And so as a result, and this is something else that came up this morning, Access to HCBS varies across the country. So one of the most telling metrics of HCBS access in the US is that which reports the number of individuals on Medicaid waiver wait lists. And so these waiver wait lists this shows the waiver wait list between 2002 to 2017. You can see in 2002, we were at about 192,000 people nationally. By 2017, we're at 707,000 people nationally that are on waiver wait lists waiting for waiver services in the US. And when I moved to Maryland, I remember one of the most striking and shocking findings or things that I learned about their wait list was that it was 7 years long. And so there has been some effort between the state and institutions like Hilltop to develop things like algorithms to prioritize those who have been waiting the longest for services alongside those that have the greatest and most pressing need. But we still deal with this sort of issue of wait lists, and a lot can happen in 7 years, right? A lot can happen in the few months that you have to wait for services. And so who provides this paid care? And the direct care workforce is a group of folks that I have been really paying attention to over the last several years. But the paid care, is delivered by the direct care workforce. This group consists of three sets of workers. Home care workers include those personal care aides, home health aides, and nursing assistants who support individuals in private homes. And I refer to those people as my people. Those are really the folks that I focus on because most of my work focuses on home and community-based services that are received at home. But residential care aides also include and consist of personal care aides. They consist of home health aides and nursing assistants who assist individuals in group homes, assisted living communities, and other residential care settings. And then, of course, nursing assistants provide care in nursing homes to those who are living there. But one thing that is universally sort of understood about the direct care workforce is that they are a vulnerable group of folks, right? So they are a vulnerable group of folks caring for another group of vulnerable people. They're overrepresented by women, racial and ethnic minoritized groups, and immigrants. They are characterized by their low wages, or it's well understood that they are undervalued and underpaid. The average hourly wage was $15 an hour a couple years ago nationally. So as a result, you can imagine there's high turnover. They also receive minimal training for their work, especially dementia-related training. And they often provide their services through home care agencies or deliver services through home care agencies. Although one workforce that I won't necessarily talk too much today about is the gray workforce, which is folks that are hired privately by families and not through home care agencies or state programs. And so who receives paid care? So this table shows findings from the 2011 National Health and Aging Trend Study. NHATS was first fielded in 2011. And it has included follow-up interviews. It was resampled in 2015, more recently in 2022. Of note, if you look at the first row, paid help is used by those with the greatest level of need. Half of the people who need help with 3 or more self-care or mobility activities receive paid help. And over a third of those with any need for assistance receive paid help. It's also important to highlight the bottom row, where we see the percentage of people receiving help from both paid and family or unpaid helpers. And so I'm going to talk about family care partners shortly, but I just want to put a pin here to emphasize that overlap, that paid and family and unpaid caregivers are often working alongside each other or together to provide care to older adults that live with disability in the community. And so all of these things, the things that older adults need and receive help with, the family members and paid helpers that assist them, the conditions of employment that of the direct care workforce, the larger context of Medicaid HCBS funding, they all exist across time in different levels of geography and policy. And so as I move through this presentation today, I want to first highlight a framework that our research team recently developed to better understand long-term services and supports use and subsequent care experiences. So we've done work to develop a long-term services and supports framework to help researchers and policymakers better understand the state and local place-based characteristics that are associated with care experiences of older adults. We leverage the NIA Health Disparities Framework, as well as a few other frameworks and models to inform what you see here. So the main takeaways from this, because I know there's a lot of words on here on this chart, but it's published, so you're more than welcome to take a look at it and cite it. But we categorize these characteristics across 3 environmental domains, those being social and economic, healthcare and social services delivery, and built and natural physical environment domains. And then 3 environmental levels, so societal, community context, and household levels. We also acknowledge that the quality of services and the adequacy of policy and practice implementation varies by geographies. And we call attention to key populations, including racial and ethnic minoritized groups, socioeconomically disadvantaged populations, rural populations, disabled populations, or those living with disabilities, and sexual and gender minority groups. Much of my work is situated in what we identify as the healthcare and social services delivery domain, which focus on healthcare and LTSS financing, the direct care workforce, and family caregiving to understand ways to better address inequities in long-term services and supports. And so with that, I'm going to highlight a couple of projects that I've worked on to better understand and begin to address the needs of older adults from racial and ethnic minoritized groups and those living with dementia. And so the first project I'm going to talk about was actually done recently with colleagues here at the university with Dr. Tatiana Shippey, led by Dr. Tatiana Shippey, Eric Jukowitz at Brown. And we conducted work, and I'll talk about it in a few minutes, using the National Core Indicators, Alzheimer's and Disability, or Aging and Disability Survey data, But first, to sort of put this work into context, older adults from Black, American, Indian, or Alaska Native, or Native Hawaiian, or Pacific Islander groups experience worse health care and health outcomes relative to their white counterparts. Despite having higher risk profiles than non-Hispanic older adults, we know that research shows that Hispanic older adults often report better mental health outcomes and lower rates of several chronic conditions and lower mortality rates. And Asian older adults are generally living with better health outcomes than white older adults, apart from those living with poverty. So recent evidence shows that low-income Asian older adults experience more physical, cognitive, and functional disabilities relative to non-Asian older adults. And so these diverse racial and ethnic minoritized groups oftentimes have unique experiences when it comes to accessing home and community-based services, as well as using and their resulting care experiences. But we know that HCBS continued to be favored by consumers and policymakers. And research on racial and ethnic disparities in paid care is limited and mixed as it relates to access and experiences. So there are there's some evidence of disparities in outcomes, such as hospitalization. So for example, among HCBS participants, Black older adults with dementia are more likely to use or experience hospitalizations. We also know that Medicaid can act as a pathway to paid help for everyone, but especially for Black older adults and Hispanic older adults who are more likely to be enrolled in Medicaid than their white counterparts. And we also know, and research that I've done has also demonstrated that racial and ethnic minoritized groups are underrepresented in settings such as assisted living. We know that there are disparities in the initiation and provision of services like Medicare home health. And finally, these observed differences in access may be a result of several factors that could include service availability, literal geographic availability of services, or the lack of culturally tailored services, be it via food, be it via language, so on and so forth. And so we also see that there are racial and ethnic disparities in care experiences as well as care quality. We know, again, that Black HCBS consumers are more likely to experience hospitalizations. But we also know that there are racial and ethnic and geographic differences in the quality of Medicare home health agencies. Dr. Fashaw Walters has done quite a bit of work describing those disparities. And the thing that we were interested in this study specifically was what racial and ethnic differences we saw in unmet need for services. Now, unmet need has been documented in broader community dwelling populations. You might hear people talk about adverse consequences due to unmet needs. So, for example, going without bathing or dressing because nobody's there to help you. We were specifically interested in unmet need for services that people might need or say they need. And so that is less understood. That's less understood, especially looking at racial and ethnic differences. And so one key barrier to increasing the knowledge base on unmet need in HCBS is the lack of available data sources that include information about service use as well as potential quality metrics. Another data limitation is related to the lack of sufficient sample sizes to account for more diverse groups of people. Also, existing studies are dated. They often focus on one state. More recently, though, efforts like the National Core Indicators, Aging and Disability, or NCI-AD survey offer promising data to better understand the self-reported care experiences of HCBS consumers. There's been a limited focus on unmet needs related to specific service use, such as delivered meals or transportation or personal care, which is necessary to gain expertise and understanding about potential interventions. And the NCI-AD is a collaboration between Advancing States, Human Services Research Institute, and state Medicaid, aging, and disability agencies to track care quality. The survey data are collected through annual surveys administered by state agencies to a sample of at least 400 older adults and adults with physical disabilities receiving HCBS. And the sampling and recruitment strategies vary by state. States may construct samples from Medicaid, HCBS waiver, and state programs, Older American Act programs, or nursing homes, so long as their sampling methods align with the parameters of the study's protocol. And so we leverage data from this study. So our research question was, how do unmet needs for publicly funded HCBS differ by race and ethnicity? And so our data come from 4 study waves of the NCI-AD administered between 2015 and 2019. There were 32,450 older adults aged 65 and older who completed the NCI-AD between 2015 and 2019. We excluded people who were not community dwelling, who were missing data on race and ethnicity since it was our independent variable of interest, and states with high missingness. We excluded folks as well. And so our analytic sample resulted in 21,739 people. The services that we assess that the NCI-AD asks about is whether people are receiving personal care services, homemaker and chore, all the way down through caregiver support. And then we use descriptive analyses for our study population to understand our study population or describe our study population. We also examine the overall prevalence of service use and unmet need by service category and race and ethnicity. We use logistic regression models to identify predictors of unmet needs, and our covariates included demographics, health diagnoses, social factors, current service use, year, and state fixed effects. And we use multiple imputations for missing data. And so for the sake of space, I did not include the full list of covariates, but this table just shows the racial differences on select characteristics. So our sample mostly consisted of female HCBS participants, although Asian participants we see were less often female. Asian consumers were also the oldest in our sample. They had higher rates of dementia and lower rates of Medicare enrollment. They also had higher rates of Medicaid enrollment and were the least likely of all groups to live alone. And then also would point out that white older adults in our sample were more often living alone. You can see that the publicly funded programs that people receive were made up of those receiving services via Medicaid, those receiving services via the Older Americans Act, and those receiving services via PACE, so the Program for All-Inclusive Care for the Elderly. And so unmet need was most often experienced for homemaker chore services, personal care, and transportation services. This was regardless of service use and across most racial and ethnic groups. Unmet need for adult day, caregiver support, and delivered meal services did not exceed 6% for any racial and ethnic group. We see that unmet need for unmet chore services, homemaker chore services, ranged from about 10.5% for other race or both multiracial consumers to 13.8 for Black consumers. For personal care services, unmet need was least often experienced by Hispanic consumers and most often experienced by racial consumers. Asian consumers. And unmet need for transportation services range from 9% for Hispanic consumers to about 12% for Asian consumers. So lots of sort of variability happening here in terms of unmet need. But the next two figures represent the adjusted odds ratios of experiencing unmet need in a given HCBS type after adjusting for all covariates. Each model also includes an adjustment for each service of interest. So for example, after adjusting for all covariates and the use of personal care services relative to white participants, unmet need for personal care was more often experienced among those who were Asian or Black. Additionally, Black older adults were more likely to experience unmet need in delivered meals compared to white older adults. Asian and Black older adults were also more likely to experience unmet need in adult day services, and Black older adults were more likely to experience unmet need for caregiver support relative to white older adults. And so from this study, we see that unmet need is more often experienced by Asian and Black older adults, and this may be a result of limited cultural competency within HCBS. So again, the lacking staff who speak languages other than English, and probably a few other examples that we can think of. Additionally, Asian Americans more often were living with ADRD or dementia. They were more often living with family. They were more often receiving services by Medicaid. And I think an important part of the Medicaid program is that the services that you receive are not endless, right? There is a budget. There are budget restrictions. And so care plan budget restrictions may exclude people from receiving the amount of help that they require. The presence of more expansive family networks may also lead to the assumption that less support is needed from HCBS. And so we saw that our research shows that we know that Asian, Black, and oftentimes Hispanic and other Black and Brown communities have larger family and non-kin or unpaid family and friend networks, but that may lead to the false assumption that less support is needed from HCBS. And a lot of times HCBS programs are not assessing the willingness or availability of family. There's the assumption that the family is there and can provide help. And so again, these findings have several implications for the equitable distribution, access, and subsequent quality of HCBS. And so while the prior study highlighted the unmet need for services, it's hard to imagine that the sole solution for addressing these issues is simply providing more services. In reality, there are a lot of things that we're unable to account for, including the components of actual service delivery that take place in the home. There are many, but I have been primarily focusing on the collaborations between family care partners and paid caregivers in Medicaid HCBS, especially for persons living with dementia. And so this work is supported by an NIA K01 Career Development Award, and will develop an intervention to improve collaboration and information sharing between family care partners and paid caregivers of people receiving Medicaid home and community-based services in Maryland. First, it is important that we acknowledge that older adults living with disability in the community often rely on a network of helpers that include both care partners and paid caregivers. They may collaborate with paid caregivers when the needs of care recipients extend beyond paid caregiver availability, or when it is more efficient or effective to work together. Paid caregivers and care partners may also assist with tasks independent of each other, right? Somebody's responsible for one task, somebody's responsible for another, such as one person helping with bathing and another with toileting. Paid caregivers may also be preferred for activities that family members are unable to do, feel uncomfortable doing, or where their help is not wanted by the person that needs the assistance. There really is a lot of collaboration that is happening in the home when we're trying to deliver these services. And so paid care also impacts family caregivers or care partners in several ways, especially among those who care for people with dementia. And these experiences are not necessarily all the same, right? So this is from a study by a colleague of mine, Jenny Reckery, out of Mount Sinai, where they used data from the 2015 National Study of Caregiving to examine the experiences of dementia caregivers related to the use of paid help. Those who received paid help on a full-time basis less often experienced exhaustion, feeling like caregiving was more than they could handle, not having enough time for themselves, as well as all of these participation activity restrictions. Interestingly, those receiving part-time support from paid caregivers report difficulty and restrictions more often than those who receive no care. So this could be for several reasons, including the need for more support from paid caregivers, right? So needing more help, or just the sheer amount of coordination that it takes to both coordinate the paid care and also deliver some of the services that you need for yourself. Ooh, what'd I do? I'm going the wrong way. Okay, there we go. Okay. And so taken together, all of this information indicates a need for innovative methods to support older adults with dementia and their family care partners in the community. Additionally, in recent qualitative work, I sought to understand how paid caregivers were integrated into older adult care plans, and participants included in this qualitative study included home care agency administrators, nurses, and direct care workers. And so this quote is from a home care agency administrator, and it highlights the additional effort needed from HCBS on both sides. So I'll just read it. Families of people with dementia they're always anxious. They're always wanting to know if you have someone with just companionship or a different type of care. They don't really care about the day to day, whereas people with dementia, they want to know everything. And so on the family care partner side, there's the additional strain of making sure that all the pieces are fitting together, right? On the paid caregiver side, it's the additional work that it takes to make sure that family care partners are comfortable with and approve of the care delivered to their family members. So there really is a pull in both, or tension in both directions. So there, to this point in time, there has been little understanding generally of how this collaboration manifests in home care. And so for this project, we focused on describing what we call role sharing, which reflects or occurs through working together to complete a task, such as a care partner and paid caregiver, helping with transferring to the bathroom at the same time or alternating this responsibility when one helper is not available or coming in for that day. Another example of role sharing is when a caregiver may set up each other's responsibilities, such as a care partner leaving a prepared meal for a paid caregiver to deliver or warm up. Role sharing between care partners and paid caregivers can be beneficial, but may also impose challenges. So while care partners and paid caregivers have deep knowledge about those they assist, misalignment in expectations, gaps in information about the older adults care plan, and the lack of shared understanding about each other's roles may inhibit this collaboration. Role sharing may also fluctuate with respect to specific activities of variable intensity and time demands, such as actually needing to provide hands-on assistance with bathing versus medication reminders, right? The different loads to carry. So the prevalence, so given the recommendations to better integrate paid caregivers and home care team collaborations, a critical first step is to descriptively understand how care coordination exists or manifests between care partners and paid caregivers. So the present study expands our understanding of older adults care networks by examining the intersecting roles of care partners and paid caregivers across specific tasks. So first, we examine whether and how role sharing varies by older adult sociodemographic, health and function, and caregiving network characteristics. Second, we describe the prevalence by task of reliance on paid help only, care partner only, family care partners only, or role sharing. And because dual enrollees, Medicare and Medicaid dual enrollees, and older adults living with dementia are more likely to use paid care, we specifically examine such patterns by Medicaid enrollment and dementia status. We expect that care arrangements will fluctuate across tasks and characteristics, and that role sharing will be particularly pronounced among self-care and mobility activities, since they are essential activities of daily living. Due to a greater reliance on paid care and more expansive care networks, we also expect that role sharing will be more prevalent for dual enrollees and older adults who are living with dementia. And so we use the 2015 NHATS. Our sample consisted of 440 older adults who were age 65 and older and receiving help with self-care, bathing, dressing, eating, toileting, mobility, indoor and outdoor help, and transferring in and out of bed, and medical care activities, which consisted of medication administration and doctors and receiving help with doctors' visits. We construct a caregiving network measures from the NHATS OP file. If anyone's familiar with the NHATS, the OP file includes or provides a roster of unique helpers. So for every person that's interviewed and reports that they have a helper, there is a roster of these helpers that provides information as far as the helper relationship to the older adult, activities for which they provide help, and whether they were paid. This roster includes information about family members, so children, spouses, other family who may live or not live with the older adult. And it's possible that children or other family members we paid for their help, such as through Medicaid self-direction. And we categorize children who were paid for providing help as family care partners in this analysis rather than with paid caregivers. And we can talk about that if anyone has thoughts, because it's been something that has consistently played in our minds. So we include several older adult characteristics, including dementia, Medicaid enrollment, age, gender, all the way down to the number of hours received per week, hours of care received per week. We conduct descriptive analyses using Pearson's chi-square analysis and unadjusted logistic regression models to assess the association between Medicaid enrollment and dementia status and experience role sharing or reliance on paid help only by task. And so this first table shows social demographic and health characteristics of community living older adults with disability receiving paid care by experiences of role sharing. Significant comparisons are reported in the bold text. So first, we identified a little over 1.6 million older adults who are receiving help with self-care, mobility, or medical care activities. Role sharing, about a little over half, right? 53% of sample members experienced role sharing. And older adults who experienced role sharing were more often 75 years or older and not enrolled in Medicaid. This is a continuation of the first table, but it just describes health and care arrangement characteristics of community living older adults with disability receiving paid care by experience of role sharing. So people who experience role sharing were more often living with dementia, receiving help with 3 or more self-care, mobility, or medical care activities, living with others, receiving help from larger caregiving networks, and receiving 40 or more hours of help per week. This figure shows the distribution of help across each task. On the y-axis is the weighted number of individuals. Dark blue represents receiving help from a family care partner only. Orange represents role sharing, and light blue reflects paid care only. So for example, among the nearly 600,000 people that received help with eating in 2015, 28% did so from both care partners and paid caregivers, that orange bar, or experienced role sharing. So we see that role sharing was most prevalent for toileting, indoor mobility, dressing, outdoor mobility, and eating. It was less commonly observed for medically oriented tasks. So specifically, roughly 1/5 of older adults receiving assistance with medication administration experience role sharing between care partners and paid caregivers. Role sharing was least common for those receiving help at doctor's visits. So 15% of older adults getting help with doctor's visits, experience role sharing in this activity. And it's also important to note here that many received assistance from paid caregivers only, especially for self-care activities. So 52% of people receiving help getting with dressing received help with this activity solely from paid caregivers. 63% of people receiving help with bathing did solely from paid caregivers. And it's just important to note that among people receiving assistance with doctor's visits, they had the highest prevalence of receiving assistance from care partners only. So 61% of people receiving help with doctor's visits did so from care partners only. And so the next two tables show the results of our unadjusted logistic regression models looking at role sharing. The second table that I'll show in a few minutes will look at the odds of receiving assistance with paid help only. So I've denoted the statistically significant findings with blue arrows. So older adults living with versus without dementia more often experience role sharing versus paid help only or unpaid help only, and eating, bathing, dressing, or toileting, or getting around inside of the house. We don't see that to be the case for those with Medicaid or enrolled in Medicaid. And then when we looked at the odds of receiving paid help only across these activities, living with versus living without dementia was also associated with lower odds of receiving help solely from paid caregivers with medication administration. And conversely, older adults who were versus not enrolled in Medicaid had greater odds of receiving paid help only and getting dressed, getting around inside and outside, and I believe as well as doctor's visits. It's missing a blue arrow. And so our findings advance knowledge regarding collaboration between family care partners and paid caregivers and are timely, given the growing demand for direct care. Findings reinforce the importance of medical care, activities, and home-based care. So we know that the scope of practice limits the extent to which paid caregivers can legally and ethically engage to help older adults with medical care activities, reflecting nurse delegation. Policymakers and practitioners have advocated for greater nurse delegation to support and advance the careers of paid caregivers. Some states, for example, allow nurses to delegate specific medical activities, such as medication management and blood glucose monitoring, to paid caregivers, but many do not, right? And so we still sort of contend with the issues around scope of practice. Additionally, role sharing in Medicaid may likely be impacted by the availability of family care partners, care plan guidelines, and the maximum allowable hours of care, going back and reflecting on what I reported about Asian HCBS participants and the restrictions that people find themselves in when you have to limit yourself to a certain number of hours of care per week or month. Role sharing being more pronounced for people living with dementia emphasizes the level of involvement of care partners in home care delivery for this population, right? And then again, interventions are needed to improve family care partner and paid caregiver expectations for services and understanding of one another's roles. So our study findings demonstrate that role sharing in our routine daily activities is common in paid care. Findings further support policy relevant efforts to strengthen the paid caregiving workforce via efforts that include revisions under the Medicaid HCBS to increase paid caregiver compensation, as well as the Recognize, Assist, Include, Support, and Engage the Raise Family Caregivers Act. Future directions include interventions that align with these national recommendations to increase the understanding of and strengthen relationships between family care partners and paid caregivers. And so as I begin to near the end of this presentation, I'm going to shift to discussing a few strategies that are currently being used to support older adults with dementia and their family care partners, as well as the paid care workforce. And so I wanted to highlight this paper that's published a few years ago that few of us collaborated on that are here in the room, led by Dr. Shippey. Our team provided recommendations for how to address disparities in racism in LTSS. And these are just a few examples. There's a full table, right, in that paper, but these are just a few examples that are specific to home and community-based services. So for example, We made recommendations about addressing issues related to Medicare and Medicaid reimbursement. And an example of a policy recommendation would be to target increases to Medicaid reimbursement that are tied to direct care, public reporting of quality. CMS should lead efforts to create an overall measure that's meant to capture provider, ability to meet the needs of diverse population, Medicaid waiver, Medicaid HBS waiver programs, expanding the ability of assisted living providers or incentivizing them to accept more Medicaid waiver residents, and then HCBS program design, getting at that culturally competent care that I've talked about a few times today. And so there has been some movement, right, since that paper came out. We know that this past spring, in April 24, CMS passed their final rule or issued their final rule that requires that states, and again, there's a long list, but these recommendations are particularly relevant to some of what I've discussed today. First, that they establish beneficiary advisory councils comprised of Medicaid beneficiaries, their families, and or caregivers, meaning paid caregivers. Report the percentage of Medicaid payments for homemaker, home health, personal care, and habilitation services spent on compensation to the direct care workers. So transparency in Medicaid HCBS spending is suggested and requested by CMS. This one is what folks are really sort of paying attention to, generally ensuring that a minimum of 80% of Medicaid payments for homemaker, home health aid, and personal care services be spent on compensation for direct care workers and not spent on administration or overhead. And then report on waiting lists in Section 1915C waiver programs. And then there were many recommendations that came out of the research summit last year on dementia, the Dementia Care Summit. And I just wanted to call out a few that align with our discussion today to address disparities and support older adults with dementia and their family caregivers as it relates to paid care. So some of the recommendations that came out of the summit included examining how healthcare policies and payment models differentially affect access and quality of care received by people living with dementia to better guide interventions. Another recommendation is to conduct culturally informed research on caregivers' well-being and the provision of caregiving supports and services. And then finally, conducting research to strengthen the direct care workforce, including increasing data availability, understanding the interactions within caregiving teams, and developing equitable interventions. In the National Strategy to Support Family Caregivers, which was jointly developed by the Raise Family Caregiving Council and the Advisory Council to support grandparents raising grandchildren, seeks to increase awareness and outreach to family care partners, advance partnerships and engagement, strengthen supports and services, all the way through expanding data, research, and evidence-based practices to support family care partners. And there is a focus on paid caregivers as well. And then finally, in spring 2023, the Biden-Harris administration issued a set of executive orders to expand access to community living services, increasing supports for family care partners. Some of the key aspects of these orders included improving affordability of LTSS, improving access to home care or home-based care for veterans, enhancing job quality for the direct care workforce, supporting family care partners. So there's a lot of action. And we talked about, today we were talking about hope at the breakfast, but this gives me hope, right? All of the effort that we see sort of trickling down from our federal government down to the states and local communities to improve care for families and older adults and those with disabilities. And so in conclusion, paid care can support racially and ethnically diverse older adults that live with dementia in the community, as well as their family and care partners. Racial and ethnic disparities in paid care use, as well as care experience, do require innovative strategies to address them. And then efforts to improve paid care for older adults and care partners should be culturally adaptive and consider the role and implications for the direct care workforce. And so again, thank you for having me, and I'm happy to discuss and take questions and all of those things.
Great. Any questions from the audience here?
Well, thank you, Dr. Fabius. Again, it's such a thrill and honor to have you here with us at the University of Minnesota. I know you're a real treasured colleague of so many of us here. And
Thank you.
I was really intrigued by your second study, the role sharing. And, you know, I was thinking through, I agree wholeheartedly, certainly with the findings, and then of course with your implications. You know, one of the things that might help frame those findings more and link it to potential next steps in the research progression. Research on the interface between formal and informal care networks, it actually dates back to the late 70s, where there were attempts to categorize how caregivers utilize formal care providers like home care and types of things. And the typology would include, it was similar to what
Yep,
you were saying,
yep.
role sharing in this case. And the paper, I'm old, I know this came out in 1989, but it was basically, you know, different typologies. So for example, substitution.
Yep.
Instances where family members would utilize formal care to substitute for the care they otherwise were providing versus supplemental,
Yeah.
which kind of
Yep.
are similar to some of your terms. And the other reason why I say that is by linking back to that framework, it could
Yeah.
frame your approach and
Yeah.
findings and maybe allow for even more exciting future work, particularly longitudinally. One thing I would be interested in is how dynamic is the typology, right? Does role sharing change over time? One would assume it would. When does it? And then finally, at what point does that become necessary to actually craft a program or service intervention? Does that make sense?
Yeah, no, and I appreciate those points. And I didn't talk about the framework that we use to guide that particular study, but it's LitWax task specificity.
That's it.
Yeah,
That's
so
it.
it's the exact same thing. Talks about the motivations for and the reasons families provide care versus the reason and motivation that paid caregivers provide care. And so um yes, I agree that there's a dynamic piece here too that we couldn't really get at with this study, but you know that I'm really interested in because we know this stuff flows through time. I mean, you don't always have the same direct care worker, right? That we know that there's lots and lots of turnover. So that's why the next stage, and I didn't mention that we're moving into with the K is doing direct observations of home care visits to see what this looks like in real time. Anecdotally, I have a sense of what it looks like having done this work before I started doing research, but we're looking to understand like what that looks like, how people are setting up care, how are they sharing care, how are they identifying each other's roles at home, how are direct care workers prepared or unprepared when they show up to the door. We've heard stories about both cases, like both scenarios. So yeah, no, I appreciate that.
So one of the bullet points on your slide was that this goal of having 80% of, I guess, the financing for home care providers to go into the pockets of the home care providers, so for their salaries. Do we know what the current percentage is, like overall?
I think it varies. I don't know, but I think it varies. And I think the challenge that there is not really a requirement across the board. And so providers kind of have the ability to do what they need to do or want to do. And so I don't like to call all of these folks predatory, but I was talking this morning about the size of some of these agencies. They don't have a lot of resources. So there is challenge to implementing this, right? Without increasing Medicaid reimbursement or doing something drastic that would put more money funnel more money into these agencies. The agencies that we surveyed a couple years back, the bulk of them were only serving 1 to 10 clients. There's teeny tiny, there's small agencies. And so there's going to be challenge in implementing that. And it's still yet to be determined how exactly states are going to do that. The other thing that I will mention is that one of the, I think it was on that particular slide too, was accurate reporting of direct care workers. because there was limited understanding about who's actually working, who's providing the services, how many employees do these agencies have. And so that's also one challenge, another challenge, and making sure that state agencies are adequately funded and so that the money can funnel down appropriately.
Check online for us, Alicia, too. All right. Anybody here?
When you just very briefly mentioned something about the delegation issue between
Yes.
that nurses do and direct care providers do. And I'm a nurse, so I can say what I've been going to say. And that is, I think nurses are the problem in that they do not fully really understand what delegation means.
Mm.
So when you're delegating something to somebody who's not licensed, that would normally be done by a licensed person, you're delegating the task, but you're also delegating it in the context of the person actually knows how to do it. So the right person, the right training, they've gotten the right direction.
Yeah.
But what you're not delegating is the accountability. So you're still accountable for whatever it is you delegated. You set up systems in place, like how am I going to provide the supervision and the direction ongoing, but I don't actually have to do the task myself. So we've got to get the nurses on board about delegation.
No, I appreciate that. I think one of the other challenges with delegation is that on the direct care worker side is that more tasks should mean more money. More responsibility should mean that you're giving me a raise. But if the national average is $15 an hour, we can only expect but so much. I've read of, demonstrations that work to create a better career pathway for direct care workers. I don't know that a ton of them have been sustainable. But I think that goes to it too. It's like I can delegate more, but that's more responsibility, right? So there's that loop that takes place. Thank you.
Great, Robin.
Dr. Chaney, you talked about the tracking that is going on. And one of the things that I'm wondering is, are they tracking not only the number of employees, but also, like the years of their work, and really importantly, their race and ethnicity. So for example, we had a law come out in Minnesota that many of the smaller home care agencies, they had to move to the assisted living license to provide personal cares. And we were trying to say, how is that going to impact the number of providers available? And how does that impact the community? And where are these people going to go if they can't get the culturally responsive services? So to me, it's looking at that workforce, but also what is, the diversity within that workforce also. So do you know if that's being tracked?
So I can speak for Maryland. At the state level, no. But what I will say, and I talked about this morning as well, is that PHI is who we folks that do work with the direct care workforce really look to, because they provide a lot of information. But all of their data, most of their data comes from the Bureau of Labor Statistics. And so they're able to report on race and ethnicity and immigrant status and things like that. So we do have a sense. That's how we can say that, the direct care workforce is overrepresented by women, racial and ethnic minoritized groups, immigrants, so on and so forth. And that is the case in the DMV as well. And so, but for the sake of agencies reporting the number of folks they have, I think there was legislation passed in Maryland, and my coalition folks will look at me sideways if I don't get it right. But there was legislation passed in Maryland that requires, this past legislative session, that requires home care agencies to report, because of tax purposes, to report accurately report the number of workers that they have. I don't know that it requires them to report the information that you are suggesting. that they report. But I agree that that's also extremely important to know.
That race and ethnic data.
Priorities. That's why I think the conversations that we have, the work that we're doing as states have started to prioritize addressing disparities, right? Part of that is collecting data. It doesn't exist until we go out and capture it. And so I think that that's where it is. It's just that now is a good time for us to start making sure that as we're talking about collecting data, let's collect data on racial and ethnic makeup as well.
Yeah, I think we really do want to capture that because we're hoping for more equity assessments so that
Mhm.
if you take a look at, that the group impacted, take a look after the implementation of that law or regulation
Yeah.
and then say who was impacted. And the bottom line is we couldn't tell if it was a negative or a positive impact because the data was missing from the home care agencies, the state, and every place. So I just think that impact analysis as we drive forward the policies, it's
Yeah.
making sure we're capturing enough information so that we can measure
Yeah.
that impact.
I think the other thing too is in lieu of having the exact data that you need,
Mhm.
many of us have been creative in linking data sets with one another or with each other. So I talked about at lunch the surveys that we did in Maryland of home care agencies that we then linked to Inter-I home care assessment data. So where the questions are not there to understand what type of agencies are providing care in Inter-I, like in the home care, functional and health assessment, they're not there. But we were able to link those data from the surveys to that data. And so it's taken some creativity ahead of having the intentional questions that we have. So some of that might look like linking it to place-based characteristics, like I highlighted that framework in the beginning. So linking it to neighborhood characteristics, linking it to the share of direct care workers, the wages that they receive in a particular geography or level of geography. So just wanted to pin that as you were asking your question as well.
Thank you. That's helpful.
Mm-hmm.
Anyone else with a question for Dr. Chaney?
Shekinah.
Thank you so much, Dr. Fabius. Given that sexual and gender minority older adults have smaller social networks, more
Mhm.
likely to need formal services, but are less likely to access those services due to fear and other
Yeah.
systemic oppression that they've experienced. Have you done any look at the role of kind of intersectionality between race and sexual orientation and gender identity, or do you have any plans to? I know that some of the national data sets don't collect that, so it's
Yeah.
sometimes difficult, but
Well, I've not done that work. I have a colleague of mine, Elise Acre, who is new to Hopkins, who is interested in this very topic, that intersectionality between race and racial and ethnic minoritized group and sexual gender minorities. But I just want to uplift the point that you're raising, that the folks that are part of sexual gender minority groups are often overlooked in research. There are some efforts and data sets that do collect information about aging LGBTQIA folks and others, but I think that we are sort of at a sort of interesting intersection with some of these larger data sets that have not really tapped into that. But yeah, no, I have not done that work, but interested in collaborating, of course, because it's another vulnerable group that needs assistance receiving the appropriate care, as well as, concerned about the outcomes that they experience as well.
I think particularly when looking at racial and ethnic minoritized groups and sexual and gender minorities, you start to sort of slice the data so
Yeah.
thin, it can be difficult to pull out, but it's so important.
Yeah.
Yeah.
Yeah. Thank you.
Sorry if I missed this. I might have gotten lost in my own thoughts about this as you were maybe talking about it, but the non-Medicaid population, doing less role sharing? Why do you think that,
The
or the
Medicaid.
Medicaid population
Mhm.
doing less role
Yeah.
sharing? Why do you think that is?
So my thought is that for Medicaid, folks are hired for a specific reason. So your care plan reflects what help you need, and you hire a person essentially, either through agency-based care or, self-directed care to provide that service. So it may be that somebody finds somebody that can help with um meal preparation or bathing or dressing, so somebody else doesn't have to do it. And so I think that's probably what it's getting at, is that, those folks are actually receiving some of the services that they need, and and paid caregivers then are sort of taking the place of what the spouse or family members or children, whoever, would be doing otherwise. That would be my estimation.
Okay. And what about role sharing by different contextual factors, neighborhood factors, whether that's socioeconomic or
I
any
would
of the
love to
other
look at
people?
that. Yeah. No, I think I would love to look at that, because I just think that it speaks to community and how we take care of folks. We didn't do it in this study, but I definitely think that it's a potential direction, because we have those data in the NHATS, right? So we can look from state level. I mean, the other thing, so we can look at state level factors all the way down to census tract. And it also might be interesting to look at some state level factors like Medicaid generosity, state pay, the presence of state paid family leave, and other things like that, to see if there are associations with how care ends up being structured in the home, if policies have a direct impact on how care is structured in the home. But yeah, to your point, place-based factors I think are really important to look at. A good next step on the list of next steps to think about.
Any other question?
So I think I'll start with a clarifying question. Did you say in the role sharing work that the family care partners were being paid to provide care, were lumped into family care partners?
So we categorize children that were paid family caregivers. We categorize them with family. So they were categorized with the family unpaid group.
Okay.
If they were relatives other than children, we categorize them as paid. So we could be splitting hairs there, but I think conceptually we did that because they're family, and they're just they would do it anyways in a lot of cases. But I'm happy to think through that more, because it really was not an easy decision with how to split the groups that way.
I was actually going to ask you to talk through a little bit of your thought process. And the reason I asked that is because I actually interviewed a family care partner last week for my project. And she was talking about how she was trained to be a paid caregiver for
Mhm.
her mom, but she also hired somebody else to provide
Mm.
care when she's not available
Yeah.
to do that. And so that just got me thinking and going down a rabbit hole of, would the results be different if
Yeah.
you did not lump them into the same category or not? I wonder if you've done any
We could do some rearranging to see. It would be interesting to see. But I do think that one thing that came out of the study that really got my wheels turning was that the piece about paid family caregivers. Because it really does change the dynamics of care in a family when someone is compensated for it. I think the other thing that's interesting about paid family caregiving to me is that there are self-directed programs, right? That Medicaid self-directed programs that states have. There are also states that don't have self-directed programs where family members are still paid. So in Maryland, our older adult services or waiver does not have a self-directed program. So what happens is a family caregiver is hired by an agency for the purpose of providing care to their family member. And so that is interesting to me, because you are a hired employee with this agency, but you are not hired to in the same way that you would be to care for others. So when your loved one, they're not adding to the workforce in the same way that we might think they are. And so I have a colleague of mine, Kate Miller, and I, who often talk about this, is just how, what that means to have a caregiver that's hired through an agency, but is not technically working on behalf of the agency with other people. They're only there to help their family member. Are they included in, reports of numbers of paid caregivers? I don't know, probably. And so what are we, like, what does that mean? I think not, I don't know if that answered your question at all, but
No,
that's
that's
what paid family, when I did this work, I really was struck by, the sort of that impasse I was at with trying to figure out what to do with the paid family caregivers.
And I think that was already different from what the care partner I spoke to. She had to undergo different levels of training to get to that status where she's now getting paid to provide support for her
Yeah.
mom. And so it's very different in Minnesota.
Yeah, this was in Minnesota. Yeah, I think it varies so much by state. I think that was one of our questions when I did some interviews recently with supports planners or care managers in Maryland, and I couldn't really assess. One of the questions I asked of a couple of people that was outside of what we were interviewing about was, is there training for paid family caregivers? Do they get the same training that somebody else just hired off the street gets for providing care? And that answer, I don't know the answer to that question. But I do think that there's just a lot of work. I mean, during COVID, we know states expanded their Medicaid programs to be able to pay for more family caregivers to address a lot of the backlog issues in receiving services and access to care. So that is a direction that I really am interested in, or a group of folks that I'm really interested in knowing more about. Mhm.
Any other questions?
Dr. Fabius, I'm wondering what's your thoughts on provide training to the unpaid family caregiver, especially at one point you're talking about, oh, we didn't assess the willingness of family to be
Yeah.
unpaid. I guess a lot of times I saw for a family caregiver, they're not confident enough to provide a caregiving, and especially the grandchildren's generations when they're in college or high school, they're able to do the caregiving process, but they're especially lacking confidence to do that part. I just kind of wondering your thought of that.
So states do offer training a lot of times through the National Family Caregiving Support Program. I think the challenging part about family caregiver training and paid caregiver training is understanding if it helps outside of advancing knowledge or increasing your knowledge around, for example, dementia. So we were really interested in dementia training. And when we did our survey of home care agencies for paid caregivers, dementia training was the least often required type of training. Only 14% of the administrators in our sample reported that they required their caregivers to undergo some dementia training. And so I think that the issue is if the paid folks aren't getting it, where does the responsibility lie for family caregivers to receive training? There, like I said, there are opportunities for and resources available for families. But yeah, that's what comes to mind when we think about training. But when we talk about the willingness of family caregivers to provide care, I think that gets at just assessing someone's network and their ecosystem, because a lot of times we make assumptions about whether as a care manager, is this person's here with you for this assessment. What is it that they're going to be able to do? What are you willing to help with? And I would write down on the care plan that daughter is going to be helping with transportation, or daughter is going to be the one responsible for medication administration. And that's something that the family caregiver had to agree to. But that is not standard, nor is it systematically integrated into the development of HCBS in any state program that I know of. I could be wrong. There's a lot of states, but that I know of, we don't assess that information.
Hello. My question is, was there a differentiation between the types of dementia
Hmm.
and their family care, or those who were going to care for them, if they had behaviors in the training, or if they were willing at that point to still be able to participate, at what level they felt comfortable in care, and just the liability, and that might affect how they can get some type of assistance or people of help if they have behaviors, because people are shutting doors.
Yes. We didn't look at the level of severity of dementia, but you raise a good point. I think that we could look at in the NHATs at like advanced dementia versus less than advanced dementia. But no, we haven't looked at that just yet. Mm-mm. I have a colleague in Jenny Rectory that I cited in some of this work. I didn't include the slide, but that has looked at the hours of care provided. And of course, we know that people with advanced dementia receive more hours of care from paid and unpaid helpers. But to the extent that it impacts family willingness, right, and ability to care, that I can't necessarily speak to.
Any other questions?
You shared so much wonderful information. I'm wondering if you could drill down on one of your slides. It was the bar graph slide that talked about caregivers' exhaustion.
Yeah.
And I'm not sure I heard you correctly.
Yes, you
Be-
did. You heard me. I know what you're gonna ask. Go ahead.
Because I thought you said
Mhm.
that yes, I mean, I could spend 15 minutes talking with you about this slide. So I'm having a hard time differentiating the colors, but as I understand this, you said those part-time paid caregivers are more exhausted.
Yep.
I know.
Than those who don't receive any care. So first, I would like to shout out my good friend, Jenny Rectory, because this is her work. This is work that she's led, and this came out of the National Health and Aging Trend Study. But yes, the middle bar is that part-time care. The darkest bar is no paid care. So yes, people who receive part-time care are more often experiencing these negative outcomes than people who receive no care. And that's also very interesting. But I think it gets at that, like I mentioned, the sheer amount of coordination that it takes and effort. Like if you have somebody, just because you're receiving part-time care doesn't mean you don't need full-time care. So you're having to do the work to make sure that people are receiving the services and help that they need, as well as providing coordination for care. And I brought up this morning, if you've ever coordinated care for children, it's that level of trying to find helpers, and then you think about the turnover that exists with these agencies, and it just is a mental load that you have to deal with on top of then having to make up the difference. So I think that's sort of what that gets at. It really is fascinating
It
to
is.
see it in this way.
It's powerful because just adding more services isn't necessarily going to reduce the burden.
Right.
It
Right.
may increase.
Yep. Exactly. Mhm.
Yeah, I'm wondering if this model controls for anything, because I think maybe the folks that are hiring part-time caregivers, they're working full-time, so they need someone. And if you have not hired any caregivers, paid caregivers, maybe that's because you are not working and so you're able to provide care full-time, or the person that you're caring for has fewer needs. So I'm just wondering if this model adjusts for
I
any
don't
of those
think this, I think
covariates.
these are just percentages. I don't know that it's adjusting for anything, but you do raise a good point about working caregivers, because I'm sure the term sandwich generation is one that I learned when I was in grad school. And so there are just the many demands that people have, be it raising their own kids, taking care of aging parents, volunteering, working, whatever it is. There's those additional stressors that people have, and you only have so many hours in a day. So yeah, I think some of what you're seeing here is exactly related to some of that. Mhm.
Any other questions?
Oh, sure.
Related to the part-time paid givers, we went through a situation with my mom where we moved her from her 55 plus living community, where she was getting, family members were coordinating meals. They were coordinating PT, OT after, she had had a fall. And so the thought was she would have more care in assisted living. Then we ended up paying and coordinating
Mhm.
for her to have a full-time caregiver from 8:30 in the morning until 4 o'clock. And then the family members still spent from 4 to 7 to 7 to 10.
Yeah.
And we did that for 2 months. And I mean, it was way more stressful because I wanted to hire around the clock care from trusted people. But the stress went off the chart.
Yeah.
Because you had given responsibility to an agency and we kept catching them on things they weren't doing, including medication and pain management.
Yeah.
And with my mom, she just says, this quality of life is not good. I'm not going to continue with dialysis
Yeah.
because of the quality of care.
Yeah.
And so I'm just wondering how many people, make that changeover thinking it's going to provide more care, but it was worse.
Yeah.
It was 10 times worse
Yeah.
because you didn't feel like the person was safe.
Yeah.
And you knew their pain was unmanaged. So I don't know if anybody's, tracking, what happens. I know you're on the community-based side, and that's where I spend most of my work, but I'm just wondering what's happening in assisted living, and are people supplementing in assisted living? Because I know I did when I had a home care company, and the people were used to 24-hour service, and then they went into a facility, but the person was like, I'm one of 10 people. And they miss being able to have that. So we often had caregivers go into assisted living facility providing. So just don't know if you have any thoughts about that care, transition.
Yeah, I think it's similar to what you see at home. I think that it's very similar. And I don't know if you remember the quote, oh, it's right here, that I put up. And of course, this is related to people who are caring for folks that are living with dementia, but it just gets at that the level of effort that caregivers are putting, the mental energy that caregivers are putting forth, with making sure that their family member is okay, right? That they're safe, that they're happy, that they're healthy, that people are doing what they're supposed to do. And in the background, oftentimes, you're dealing with caregivers that either they move on from their job, it's not a good fit, right? You're dealing with turnover, you find somebody that's really good, and then they get a better opportunity, they move on. Like, there's all of these things playing in the background. And so I think that you're describing a situation that is not unique to assisted living. It's just that it speaks to that additional load that families carry, especially when you're caring for someone who requires assistance, right? Cognitive that lacks the ability to advocate all the time for themselves. And so yeah, just to echo what you're saying, it's happening at home too.
Yeah, I'm sorry. Does someone else have a question? I don't want to speak over me. Yeah, I mean, this discussion is so robust and your answers are so insightful, Chanee. Thank you. I think it again comes down to, for this area of research to move ahead, I mean, this whole idea of the longitudinal, you heard Robin talk about transitions, and I mean, I think you're alluding to things like the continuity of care. And I know when you talk to families who are using home health care or home services of some kind, that is such an issue with lack of continuity of care. And then finally, this idea of the coordination.
Yeah.
And it seems like with some families, maybe it was like this with you, Robin, or others, is there's a time period where it's very much in flux. The family works very, very hard. As you said, it's like this added on stressor to coordinate and integrate things. They might get it set up, and then it's another cycle of disruption. And it happens over and over. And too often in the literature, and I think even from a program delivery standpoint, we believe more services are better. You get more services, you're going to do better. And boy, that's just not the case. It doesn't work that way. And so taking this nuanced approach to the dynamics, the longitudinal aspects, I mean, that's where we have to go.
Yeah.
Like how can we offset this coordination and integration burden for families?
Yeah.
Because it just seems to be such a tipping point for so many of them.
Yeah.
And what can we do? I mean, I think that to me is the big question. None of us are going to answer it today. But,
Yeah.
I certainly your work can take us in that direction. So thank you.
Thank you. I think just to comment, and from my personal experience as well, is that families oftentimes, there is a tipping point, right? where it's like, I've done everything I can, and I tried to keep this person home for as long as I could. I've coordinated all of the care. I've done all of the things that I, tried to be a good child. I tried to, make sure that everything, but I can't do it anymore. And what ends up happening is that we're not preparing to transition into nursing facilities. We're ending up there because our hands are tied. And we went through similar transitions with my grandfather when he was living with dementia, and my father was his primary caregiver, and tried. He kept him at home for a very long time with home care, and then there was a tipping point. And so I think that, to your point, there is a lot more work to be done to understand if there is preemptive work that can be done so that families don't have to reach that like absolute point of exhaustion before making those hard decisions.
Great.
Do you have any information about like respite care for those families or programs for them to get a break?
Yeah.
I know there's not many out there, at least in the Twin Cities.
So there are respite programs. I think one of the challenges a lot of times is that families don't know where to look for these things. And we talked about this again this morning, just getting at the conversations, is that they're overlapping a lot, is that families don't know where to look for supports a lot of times. And because our long-term services and support systems and medical systems are fragmented, the systems don't talk to one another. So where there, and I think even sometimes in research, where there are researchers that will work with primary care, doctors or physicians to link family members to additional supports or help them find additional resources. We could be doing this. We do some of that same work on the HCBS side. We do some of that same work on the nursing home side, but a lot of times the systems still are working in silos. So I do think that there needs to be a lot more collaboration, because we're not reinventing the wheel a lot. But I do think that one of the challenges that the families lack the information, right, to even know where to go to find the resources that do exist in their communities.
Hi, Dr. Fabius. Thank you so much for this very insightful presentation. It's super interesting. And actually, I wanted to kind of circle back to a little bit, like tad bit earlier in our conversation, because you mentioned kind of like the caregiving side. So for context, like what's kind of like sparking this thought is that like my mom was actually, my mom and I were both caregivers for my grandparents. And like that tipping point you kind of mentioned was that we had cycled through so many like home care aides that eventually my mom was like, why don't I just get paid to do this myself? And then, so then she like actually went through a program, an agency actually in New York to get paid to take care of her to take care of our grandparents, and through an agency and through Medicaid. And I'm curious, like how many, and I don't know if this is within your scope of research, but I'm curious how many of those kind of like home paid care workers were actually former kind of caregivers themselves, because my mom has kind of ended up in the point where she was a full-time caregiver for so long that she had to keep going because there isn't another option. Like her paid employment had ended for like 10 years at that point. And so she kind of had to continue on with care. And so I'm wondering if that's also kind of like the murky line between like family caregiver and paid caregiver.
Are you a doctoral student?
Yes.
That's an excellent dissertation question. Because I don't know, that is an excellent question that I don't know the answer to. What it reminds me of, though, is the change in attitudes of paying family caregivers over time. So when I was doing care management in like 2011, right? So it's not that long ago. It's long ago, but not that long ago. I was doing care management, and there was always pushback on paying family caregivers who had provided care in the past. It's like, if you were already doing this, why do you now need to be paid? And in fact, we had more success when somebody was living with dementia, because we could justify to the state that this person will be more successful in staying in the community and have a better quality of life if you allow their family member to care for them. And that has sort of shifted as we have come to understand that the direct care workforce has the issues it has, is being able to expand Medicaid programs to pay for families to provide care. So no, I don't have the answer to that. I think that's an excellent question, to be able to, find out how long people were providing care or whether they were providing care before receiving payment for care. So please let me know when you defend your dissertation.
I'll ask a question myself. I sort of asked you this question at the morning breakfast today, but I like to think of hope and, where we can go from here, since so many, I'm sure all of us here, if you're in this room, you care about caregiving and supporting the direct care workforce. So from your perspective, Chaney, what do you see as some, I don't know, areas for hope? Maybe it's policies, maybe it's changes post-COVID, maybe it's payment for family caregivers. What are some things that I guess inspire you and motivate you as you continue doing this work, despite all of the challenges we noted?
Well, I think the things that inspire me are those last sets of slides that I showed, because I actually, they came from a prior set and I had to add more slides as I was preparing for today, thinking about the CMS final rule and things like that, is that there is action that's taking place. There are many challenges and there will always be, but I think that there is the policy pieces excite me, because I really think that because we live and are governed by policies. And I think that when federal and state governments really get a hold of something, they really can change the way that people live in their states and in our country. And so those policy pieces excite me. I also get excited when I hear about people figuring it out, right? So like the grassroots stuff that goes on and people sort of being able to be the great connectors of folks and figuring out different ways to support one another, because there is, in lieu of having policies and practices and supports. I think that's always encouraging. I find little pieces all over, honestly, because I think they're all important parts. But it's encourages me to see, as somebody who really enjoys home and community-based services and care and knows that people want to live there, even looking at the crossover and over time where states were investing their money excites me. Because it's like, okay, so there's more resources. And then I look at the map, I say, oh, what is somebody with 80% of their funding going towards AIDS? What are they doing? Like what? So all of those sort of things really make me look forward to continuing this work.
Love it. Thank you. I don't know, any other questions? Rachel, you have any comments from DHS side you want to share, since we're a state that invests 80% in HCBS, not to put you on a spot, or any other comments, questions from you? And then I'll do John. Oh, wait, let me give you the mic.
Thanks, Tatiana. I think this has just been a fascinating conversation to kind of connect the dots all the way from federal to state policy to what's happening on the ground and the experiences of paid caregivers, family caregivers, the blurry line between the two. I think that that's something that is being raised more and more. And I absolutely see it at the state level in our policy discussions and programmatic work. So yeah, just really happy to be here and listen and learn from all of you. This has been great.
Thank you. I think
Thank you so much. And John, and I think we'll probably, did it go till 4, Alicia? Okay, so one last question and then we will adjourn and then we'll have a reception.
Well, thank you so much for the presentation. It was wonderful. And just thinking back to that slide you had on the proportion of role sharing and paid help by activity, and the lowest role sharing was for that attending medical visits.
Yeah.
And that kind of made me think of like a lot of the work at the Lippitt Center about proxy access to patient portals.
Yeah.
And do you see, now that you can do questionnaires and stuff as a caregiver without actually having to attend the visit, does that open the door for more role sharing kind of in that space? Or do you think there are other kind of barriers driving that?
I think so. John is referring to our center, the Lippitt Center at Hopkins. Absolutely. I think that opens the door. There's a few things to answer your question. So there are limitations in what direct care workers can do to engage, right, with medical professionals, doctors, clinicians, right? They're not supposed to be sharing information back and forth with one another. However, in our qualitative work, and we published this in geriatric nursing a couple years ago, we did find that direct care workers, and this has been reported by other people too, that doctors do appreciate when home care aides, personal care aides are in the room, because there's additional context that they can receive about, the person. So that's the first part. But we also asked questions in our home care survey a few years back about direct care worker engagement in patient portals. Do they help make appointments? Do they help just viewing sections and navigating? And for the most part, there was little use in sort of interacting with the doctors, but they do help make appointments, right? The administrators reported that they help make appointments. They help older adults and care recipients navigate the patient portal. But we can't even, we struggle identifying family caregivers in patient portals. So the idea, the thing that I'm really interested in, some of what I'm doing with Dr. Jennifer Wolf's R35 work to better understand patient portal use is whether we are able to identify any direct care workers in like patient portal messages, whether they say this is so-and-so's home care aide in the messages, or they're being referenced in the messages, just to get a sense of what that looks like. Because as you said, there's a lot of interaction that happens outside of the physical doctor's visits. And I imagine, just based on our work and others, that direct care workers are involved in that too. We just don't know to what extent and what they do. So yes, it definitely opens the door for taking a look at that. And then there are 25% of folks that say they only receive help from paid helpers only. So what does that mean? Are they just getting transportation? Is the person going inside? We don't know. We can't tell that from this data, but definitely opens the door for additional work.
Well, thank you.
Thank you.
And thank you so much, everybody, for joining and join us for reception.
Thank you.